think you have enjoyed the ESC Digital Experience 2021 for last couple of days. It has been a phenomenal experience for all of us to have various topics to be discussed for updation and also new topics that have been added. Today, I am going to present some of the selected topics, and I'll just mention the highlights of those topics so that you can refreshen yourself with the topics you have enjoyed in last few days of ESC conference. My first topic is potassium binding in management of heart failure. Now, as you know, that potassium plays a very vital role in the myocardial activity, and whenever there is associated hyperkalemia or hypokalemia, they have got deleterious effect in the form of various kind of tachyarrhythmias or cardiac asystole. Especially, this is important when there is hyperkalemia, which is very commonly associated with heart failure. And it is also associated with high mortality and morbidity. And there is the requirement of continuous monitoring of hyperkalemia when we treat a patient of heart failure. Now, it has been found that mild hyperkalemia, which is defined as 5.1 to 5.4 millimole per liter of potassium, there is 61% maintained dose of various guideline-mediated drug therapy, and 24% may discontinue due to the mild hyperkalemia. On the other hand, when there is moderate to severe hyperkalemia, which is defined as more than 5.5 millimole per liter of potassium, you can get maintained dose to a much lesser patients to the range of 55%, and 27% is the discontinued dose. And that means whenever there is the fear of hyperkalemia, there is either discontinuation or reduction of the doses, and only a portion of the patients, they continue with the dose. Now, why it is so? Because hyperkalemia, as I told, is a very, very important factor in the overall management of heart failure, and this is not adhered to. The guideline directed medical therapy is not followed up properly, which is known as adherence, non-adherence. Hyperkalemia can lead to toxicity like events in heart failure, as I already told you. And very importantly, studies that can prove that use of heart failure therapies with MRAs and RAS inhibitors can be enabled using potassium binders are needed. So it means that if you use MRAs and RAS inhibitors and there is possibility of hyperkalemia or there is hyperkalemia, and if you treat them with potassium binders, then it can be of good use in the form of reducing morbidity and mortality. Studies that prove that use of potassium binders prevent hyperkalemia associated toxicity in heart failure are needed. So this is a very important message in this conference, that you should take care of hyperkalemia not only by lowering the level of potassium, but also by maintaining the dose of the various drugs that can induce hyperkalemia. Because RAS inhibitors are the fundamental pillars in heart failure. And obviously, there are challenges to optimize the management, but you ought to overcome these. High RAS inhibitors doses offer better cardiovascular protection in patients with heart failure. But incidentally, patients who benefit most from RAS inhibitors are the ones at greatest risk of hyperkalemia. The reason is you are increasing the dose of medicines, and that is why there is more chance of development of hyperkalemia. This is more important when you are combining the two RAS inhibitors together, like MRA, as well as the ARB, SE, or ARNI. But having said all this, RAS inhibitors remain the mainstay of heart failure with reduced ejection fraction therapy, and recommended doses must be given in full, so the benefits are also full. Potassium elevation may be perceived barrier to optimal RAS inhibitors dosing, but there may be hesitancy or inertia from the physicians as well. And this physician's inertia must be shaken off so that better management of heart failure patients are done following the guideline-directed medical therapy. I'm not going into the detail of the heart failure management with the ARBs, SE, and ARNI. I think these have already been highlighted. So you must remember that even if there is hyperkalemia, you must take care of it either by potassium binders or by reducing the dose. Now, how you are going to do that and what is happening over a period of time? Over a period of time, there can be hyperkalemia as the first event to the 39% of patients, and within average period of 6 to 2 months, the second event of hyperkalemia can event in 43% of cases, and third hyperkalemia can occur within average period of 5.3 months and to the range of 54%, and after another 4.6 months, there can be the fourth event with 60% involvement of hyperkalemia. And these recurrent episodes of hyperkalemia is very, very deleterious for the patient. And that inhibits the guideline-mediated therapy. And there actually comes the recommendation for the management of hyperkalemia. Now, guideline recommended management of RAS inhibitors based on serum potassium level is put forward. And this is based on the level of potassium level, whether it is more than 5 or more than 5.5 or more than 6 or equal to 6. Now, when there is more than 5 millimole of potassium level, then possibly if a de novo patient is there, you should not start with MRA or SE or ARB. You just wait for some time, and then you should plan for the management with the MRA and SE or ARB or ARNI with caution, because you should remember that you'll have to start those medicines as early as possible whenever the first chance comes. But when the potassium level is more than 5.5, then if the patient is having the RAS inhibitors, then you should reduce the dose of MRA, that is the aldosterone antagonist, to the extent of 50%. And if it is more than 6 or equal to 6 millimole per liter, then you should discontinue whether it is MRA, SEI, or ARB, or ARNI, and that should be followed. Now, potassium binders are effective in treating hyperkalemia and are well tolerated. They have documented safety and efficacy data up to a period of 1 year. And potassium binders also have aldosterone lowering effects. So you know that aldosterone increases the chance of the hyperkalemia. And if you give the potassium binders, they have the chance to reduce the aldosterone, and thereby they can actually help in potassium lowering. But at the same time, you must be very careful about the rebound hyperkalemia when the drug is stopped. I'll stop here regarding the hyperkalemia management and the causes and the effects. Then I'll go to a very important topic, that is modern glycemic management to reduce cardiovascular risk for diabetes patients. This is another important aspect, because as you know, the diabetes and heart failure both are going hand in hand in the epidemic form, especially in the third world country, and because of the more longevity and because of the higher level of availability of resources, as well as the infrastructures and the food matters. And that's why there is a increasing incidence of diabetes, as well as the increasing incidence of heart failure, because the longevity is also important factor in increasing the incidence of heart failure. Now, adverse glycemic measures in cardiac patients, when HbA1c fails to provide the full picture. Why it is so? Because HbA1c actually is a biomarker that provides only average picture of glucose control. It does not address the hypoglycemia and glucose variability. So now you'll have to actually remember this very important term, that is glucose variability. It means troughs and these ebbs. So that can occur in a patient, and you'll have to take care of that glucose variability, not the average glycemic level, which is expressed in the form of HbA1c. Same way, the HbA1c, both high glycemic variability and hypoglycemia are associated with adverse clinical outcomes. While HbA1c is useful, we must use additional glycemic matters for optimal management of glucose levels in diabetes. It would limit glucose variability and avoid hypoglycemia and improve overall outcome in patients with diabetes. So this is a very, very important message again, that if you want to have long-term effect of the anti-diabetic agents and diabetes control, then you must remember that it is not only the HbA1c inhibitor, HbA1c biomarker, but also the glucose variability must be taken care of. Now, what are the mechanisms of long-term effects or long-term effects of the glycemic index or glycemic variability? Now, the glycemic variability can actually cause neuronal degeneration in the form of autonomic neuropathy. It can increase the thrombosis and inflammation. It can also increase the ROS and also increase the SMC proliferation, that is smooth muscle cell proliferation. On the other hand, the hypoglycemia, which can happen with the various phases of glycemic control, hypoglycemia is associated with cardiac arrhythmias, and it is also associated with increased thrombotic phenomenon, increased inflammatory mechanism, and there can be actually endothelial dysfunction. And that is why glycemic variability is very, very importantly related with the vascular complications in diabetes mellitus, independent of actually the hypoglycemic episodes. And that's why both are to be taken care of while managing the patient of hyperglycemia. Now, is continuous glucose monitoring the solution? The answer is yet to come out in full form, but definitely like ABPM, where the 24-hour ambulatory BP monitoring has shown greater chance of survivability in the form of better control, I think continuous glucose monitoring also will be having the same phenomenon. And this glucose variability can be defined as a significant ups and downs of blood glucose levels, and it may occur despite targeted HbA1c. This is known as continuous glucose monitoring. Now, glucose variability results in vascular inflammation, platelet addition, and myocardial fibrosis. As I already highlighted earlier, the times have changed from traditional blood glucose meter to continuous glucose monitoring, and findings from REPLACE study demonstrated that the incidence of nocturnal hypoglycemia was reduced in the continuous glucose monitoring group as compared to the control group. And CGM improves glycemic control, and it also decreases hypoglycemic events, improves the cardiovascular risk stratification in type 2 diabetes mellitus. More than 70% use of CGM over the most recent 14 days correlates strongly with 3 months of mean glucose time in ranges and hyperglycemic metrics. Thus, a clear association of lower time in range with an increased risk of all-cause cardiovascular disease mortality among patients with type 2 diabetes has been established, which supports the validity of time in range, or TIR, as a surrogate marker for long-term adverse clinical outcomes. So this time in range is another factor in addition to the CGM, that is continuous glucose monitoring. Time in range means you'll have to control the variation as much, as possible, and it should be over a period of 70% or more. If it is lower than that, it means you are having lesser time in range variation, and that is actually associated with higher chance of morbidity and mortality. So I'll stop here with this particular aspect. I'll go to the next very, very important topic, which is very close to my heart, that is human versus AI for ECG interpretation. Now, AI, as you know, is also known as artificial intelligence. It's also known as augmented intelligence, and it is more so as an augmented intelligence because AI itself possibly cannot give all the help what we imagine, because of the fact that human intelligence actually developed over a period of a few 100 million years, whereas AI is a new phenomenon, so it will have to develop further. But at the same time, many of the AI features, actually, they give a lot of inputs very, very quickly, and thereby the managements also become much more easier and much more faster. And similarly, the ECG is another parameter which can be interpreted with AI in a much more quicker fashion. Now, this feature, ECG interpretation, is vital to the diagnosis of several cardiovascular diseases. With AI-enabled reading coming in during the recent times, the comparison between the human intelligence versus AI-enabled reading is interesting to see. And AI-enhanced ECG interpretation can see things that human eye and brain cannot see, as you have seen with the Google described retinal findings, which can interpret the retinal involvement and a guiding factor for the diagnosis of coronary artery disease much ahead of time. Studies on screening cardiac contractility disorders using AI-enabled electrocardiogram shows that the sensitivity and specificity of AI-enabled ECG reading is significantly high, more than 86%. Also, the area under curve is actually, this is the area under curve, is also very, very significantly high, and that can be used for screening purpose. And this can be of benefit both for the analysis, for primary analysis, main analysis, as well as the secondary analysis. As you can see that the area under curve for the primary is around 0.87 and secondary for 0.90, and the sensitivity is 79% in primary and 82% in secondary. Same way, specificity is also high with 79.5 in primary and 83% in secondary. So this is very, very important that with AI-enabled ECG, you can actually detect both the primary event as well as the secondary event very quickly. And it's very interesting that the threshold can be achieved much more earlier, even 4 months or 4 months before the clinical events actually happen. And this has been shown here that the AI-enabled features actually detect the problem in a 67-year male much more earlier than the clinical event has happened in that particular patient. Human interpretation of ECG is fundamentally flawed because of the fact that it is still developing, and we must have much more confidence interval to the range of 90 to 95%. It is still much lesser. But this is an ongoing phenomenon, and standardization of computer-based ECG is yet to be done, and it's a continuous process. All AI learnings have been developed from the learnings of clinicians. It's actually so many clinicians gave their inputs, and they have been put in the computers for deep learning and machine learning, and they ultimately interpreted, and ultimately the AI algorithm was formed. And several studies that analyze this AI-enabled readers use ECG graphs from textbooks from a data is not a very diverse population. The studies are retrospective clinical data and are not real evidence, prospective real studies conducted across multi-centers. And that's why there can be a little bit hesitation in the AI-enabled ECG interpretation. And most of the data actually were collected from the German-based studies, PTB, and that's the big database, and various workers have gone into the formation of the algorithm, and accuracy rate were quite high, and that's why the recommendations are going on in favor of AI-enabled ECG, though there are certain contrarian opinions in this phenomenon. And but to summarize, AI-enhanced ECG interpretation is not the prime time for early diagnosis of acute early myocardial infarction. In this setting, integration of symptoms, clinical signs, ECG changes, and biomarkers are more critical, and relying on ECG perfected by AI methodologies would be a phenomenon to be followed up. In fact, one of my close friends and very great worker in STEMI management, Dr. Samir Mehta, who is developing a single lead ECG to interpret the acute myocardial infarction in hyperacute stage or in a very acute stage. And from that single lead ECG, possibly the whole phenomenon of the early intervention in the golden period can be done. And thus the changes are still going on, the studies are still going on. And once these really come into the picture in the overall management of myocardial infarction, there will be a paradigm change. With these few words, I now close my talk. Thank you very much for your patience hearing. Namaskar.